So our next speaker is Dr. Steve Anderson. For those of you that don't know Steve, he's from Minnesota. You can tell I trained up there. I know how to say it right. For 25 years now, over 25 years, he's really been involved in a lot of medical missionary work, short term, anywhere from a couple of weeks to several months at a time. And he's an outstanding MSICS surgeon. I've been involved in COS here as far as teaching MSICS, especially to our younger ophthalmology crowd. And those interested, and he's been really quite good. He's worked all over, so we welcome you and thank you for being here today.
Well, it's an honor to be here to talk about this procedure. It's certainly been a wonderful part of my career, and thank you for the invitation. This is 25 minutes on MSICS, which is only going to be a bit of an introduction, hopefully a few little tips here and there, and some perspective. There was a wonderful email sent out about a symposium done, I think, a couple of years ago on MSICS that I would encourage all of you to take a look at if you want to learn more and hear some varying opinions on parts of the technique. So I have a couple of questions in my one of my initial slides. I might as well ask them now while we're waiting for this to load. How many in the crowd have done MSICS? So quite a few. Wonderful. How many would like to learn MSICS? How many not sure? How many have no idea what MSICS is? A lot of the residents are, okay. So MSICS is not taught in the vast majority of residencies, and I think it's actually, we're losing our extra cap skills as a field, and I think it's actually a real need that we have. So we'll talk a little bit about the need for MSICS, both abroad and here, and then talk about some aspects of the procedure, hopefully throw in some pearls in there, and then and talk about a few challenges as well, and then a little bit on training. So it's a little bit of a potpourri, going to be a little bit fast, but it's meant to be kind of an introduction. So we've gone through those questions there. And in order to talk about the need for MSICS, we need to talk about global blindness. And around the world, there are about 49 million people blind around the world. There's different statistics as you look this up, so I'm not going to hang my hat on that one number, but there's a lot. And about half of that is due to cataracts, and 90% of the blind live in the developing world. I guess I'm not advancing here. There we go. So these are some of the questions to ask as we're thinking about the developing world, and what's the best kind of procedure? What are the types of cataracts that we see there? What is a sustainable procedure? What's a procedure that's going to give us the least amount of complications? In a lot of the settings you operate abroad, you do not have vitreoretinal backup. So if you're going to be a hero with phaco and take out that black cataract, but you drop a significant number of nuclei or pieces of nuclei into the vitreous, those patients are not going to be able to see a vitreoretinal surgeon. Not everybody has a Ben Roberts down the street to help them out. So you want to have a very reliable procedure that's going to be a low complication rate in some of the most advanced cataracts that you'll see in your career. And then also to kind of touch on what is the role for MSICS in the US. So here's our options for cataract surgery. Couching, which is thankfully not a popular technique. Intracap, also not real popular. Extra cap, and then we have our standard extra cap, phaco, and then MSICS, which is manual small incision cataract surgery. Some people refer to it just as SICS, C-I-S-I-C-S. And where did it come from? Just as a bit of a divergence, and if anybody has more information about this, I would love to hear it. But I'll tell you what I know about it. Over 20 years ago, I was first exposed to the precursors of this technique in Kenya by David Yorston, who was a British ophthalmologist. Been in Africa for about 15 years. And I had just come out of my residency, and I was there for 2 days, and I was in the OR with him, and he did the first case, and he said, "How about you do the next one?" And I had never seen anything like it. At the time, he was doing a superior incision, scleral tunnel. They put 3 sutures in at the end of the case. I said, 3 sutures? And he said, "Is that too many?" I thought, this is malpractice. I was used to the standard extra cap. We're putting 8, 10, 12 sutures in to seal these leaky wounds. Well, after I saw what he did and he trained me in what he was doing, I never went back. I have never done a standard extra cap since then. And since that time, it's evolved into a sutureless technique and developed the name of MSICS. And did he invent it? He thought he did. And he'd actually made a video that he was going to present at a conference in the UK. When doing his research, he found a video from an Indian ophthalmologist doing basically the same procedure. And later in life, I've found several other surgeons who seem to have developed some of these techniques on their own in high demand, low resource areas. So I really, as far as I know, I can't credit one person with this technique. I think this came from excellent surgeons who were looking for a better procedure in those kinds of settings. So, and again, if anybody has any other information, I'd love to hear it, because I think it's interesting that it may well have just oozed up through need and good surgeons around the world. So why not just phaco everything? Phaco works really well for our practices here in the US. Well, it's very technologically dependent. The technology needs maintenance, it's very costly, and you need training, all of which are in short supply in the developing world. And also, maybe most importantly, and this applies to us here in the United States, there's an increased complication rate when we're doing real mature cataracts with phaco. That jackhammer picture on the bottom left there, I use this analogy for my patients here in the United States. You know, if someone sends me a mature cataract, or one walks in, or maybe they've got Fuchs dystrophy and a fairly dense cataract, I'll use this analogy that our phaco machine is basically like a little jackhammer, a little ultrasound. And to use a jackhammer on mud versus granite, you're going to use exponentially more energy getting through granite than you will through mud. Same thing happens in the eye, and that energy is translated to the cornea. So you might do a heroic phaco on a black cataract and then ruin their cornea. Whereas with M6, you have zero phaco energy and fairly gentle on the anterior chamber. So this study, I believe, has been cited at this meeting previous years, so I'm not going to go into the details of it, but it was David Chang and Dr. Rui in Nepal who did a great comparison study of M6 versus phaco. So if we're going to consider M6 as a procedure, how does it compare to our gold standard here of phaco? And it turns out that both did very well. M6 had less corneal edema, was faster, less expensive, and the conclusion was that it may be the better procedure for advanced cataracts in the developing world. And I think most people who work in the developing world with advanced cataracts would change may to is the better procedure for dense cataracts in the developing world. So for the phaco surgeon, is there an indication for this procedure here in the U.S.? And are we better surgeons if we have this in our toolbox? And I would argue that yes, indeed, I think there is a role for it. It's been interesting to me over the years. I would say I'm doing more M6 in the United States today than I was 10 years ago. And part of that is once you develop your skills in M6 and you're not afraid of the more dense cataracts, your colleagues around the area, when they see one of these, once or twice a year, tend to send them to you. So your practice in this will start to grow. And I think it's kind of fun to be able to do some of these cases. So I'm going to step out here so I can see my slides, actually. These are some of the indications that I have for M6 in the U.S. You have a real dense brunescent cataract, Fuchs dystrophy with a more advanced cataract, or maybe not so advanced cataract, but the previous eye didn't go so well with what you thought was going to be fine to do phaco on. Subluxation of a crystalline lens. Really challenging to try to do that with phaco. With M6, not so much. It's still a challenging case, but you've got a lot more options when you've got a wound that you can take the lens out, even as an intracap, essentially, if you need to. And I've done that a number of times, and that wound works beautifully for that. And if you've had troubles with previous cases and using phaco, nice to know either as a backup or as a planned procedure. Going forward, unplanned M6. This has happened on occasion. It's not real common, but it's nice to know you can do this if you find something unexpected. You start your phaco case and the lens just drops on a hinge, and that's happened to me. And you're not going to phaco that, obviously, and instead of just closing up and sending him off to your favorite retina specialist, you can actually approach this from an M6 standpoint, enlarge your wound, and take that whole lens out in one piece. So this is what I do. I tend to operate temporally, both with phaco and with M6. The red line would be my clear corneal phaco incision that I started with, and what I found is I can just do a wound under wound approach. And if I connect the dots of the wounds, it doesn't seem to matter. The wound still closes. If you're not comfortable with that, you can shift your wound. If you're operating temporally, you can shift superiorly with your M6 wound. And it seems to work very well. Can't say I've done hundreds of these, but I've done a number of them, and they do seem to work very well. It is more challenging with a softer eye to get your wound constructed properly. So just FYI, probably better to start with M6 if you think you're going to go there rather than try to convert. It's always more challenging to convert midway through. So other possible indications for M6 that you might use abroad and here in the U.S., secondary IOLs. It's an excellent wound for that. And for our retinal surgeons in the crowd, I would encourage you to consider this wound when you're fishing out one of our lenses, our IOLs that fall into the vitreous. A lot of the cases like that, they have a paralimbal wound or even a corneal wound where you've gotten the lens up out of the vitreous, you need to get it out of the eye. So this wound is going to induce minimal astigmatism. It's self-sealing. You certainly can suture it if you want to, but I think it's a much superior wound than the corneal sections that I sometimes see. And then it opens an opportunity for you to serve in a lot of places around the world where phaco might not be a tool you can use on a ready basis. So let's talk a little bit about the procedure itself, throw in a few pearls and pitfalls, and this is going to be kind of a rapid pace of what M6 is. So this is the basic procedure in one slide. You're going to make a scleral tunnel incision, take the nucleus out in one piece, put in the lens, and you're done. So main steps. We'll do a little bit more than that. Wasn't that fast. So the main steps you want to kind of focus on is your tunnel construction. It's different than what we do with phaco. And then delivering the nucleus from into the anterior chamber, which is also something we don't typically do with phaco, and then taking the nucleus out. And the Simcoe IA, again, I just want to do a quick poll. How many of you used the Simcoe IA? Good, it's the majority. And the residents often haven't. I would encourage you, during your residency, find one of your attendings who've used a Simcoe and just say, hey, can I try it on my standard phaco case? And just get used to using it. It's actually a wonderful device. So these are some of the parameters on how I do my corneal wound, my corneal scleral wound. Apex of the incision, 1.5 to 2 millimeters posterior to the limbus. I usually am dissecting at about half scleral thickness. Your initial incision can be a little bit deeper than that, allows you to get at that half thickness better. And then the tunnel incision is a slightly wider internally than externally. So if you think about a bow tie with an asymmetric bow tie, the internal wound a little bit bigger than the external wound. And then you want to advance your tunnel approximately 2 millimeters onto clear cornea. That gives you that self-sealing wound. And one pearl is to drop your wrist when you get to the cornea. The sclera has got a curvature and the cornea has got a completely different curvature. If you're making a beautiful scleral dissection and you don't move the tip of your blade, you're going to go right into the anterior chamber of the limbus. And it's not the end of the world, but you're not going to have a self-sealing wound. And you're going to have some iris prolapse. And then that bow tie configuration, kind of good to kind of keep in mind. I made a mistake training some residents once. I was abroad, and they had wrist rests. They were used to operating superiorly, and we switched to temporally, and I didn't pay attention to the fact I don't use a wrist rest, and they were not able to drop their wrist. And one resident after another went right into the anterior chamber early. And finally, I sat down where they were sitting, and I was like, oh, you can't do this operation this way. No wonder. And that was my fault as the teacher. But just that really taught me to kind of emphasize that point. So here's the tunnel construction, and I'll see if I can make this work. You have to kind of click on the picture itself. Let's see if we can make this video work. Can you do that for me? Here we go. Maybe it's not going to work. Anyway, this comes from Glenn Strauss's DVD teaching series. It's excellent. I've got a slide at the end that'll tell you about it. So the keratome entry, once you've made your scleral corneal tunnel incision, you've made this beautiful incision. Don't negate it by going in early with your keratome, which is a very easy thing to do. I've done it a number of times myself, and I look back, how did I do that? I thought I was in the right place. But trick that I've found is to take the tip of your blade, wiggle it. As you're going forward, it's a sharp blade, and that tip is really easy to catch. So wiggle it until you get to the very furthest extent of your corneal dissection, visualize it, and then dimple down and go in. What I tend to do, I do a continuous rhexis, and if Glenn, I don't think he's here today. If he was here, he'd be rolling his eyes and smiling at me, saying, why do you do that? Just do a can opener, but I do, and I do it on about 95% of my cases, and it works. I tend to go in just with my keratome, so I basically have my clear corneal phacoincision opening at that point. And that keeps that anterior chamber more full. Once I've done my rhexis, then I extend it side to side. If you're doing a can opener, you probably can extend it, just initially. So talking about capsulorhexis, different ways of doing it. I wouldn't say there's necessarily a right or wrong. I do a continuous rhexis. I'm used to doing that. I'm a phacosurgeon. I've done a lot of these, and I'm very comfortable with it. And like I said, about 95% of the time, I can get even the large nuclei out through a continuous rhexis. I find less vitreous loss with it, and if I need to put a lens in the sulcus, I've got a nice platform. But I do use a can opener occasionally, and I'm very willing to extend my rhexis as needed. There's V-shaped capsulotomies. The linear capsulotomy is how I first learned this before Trypan Blue came along, and I've got a slide I'll show you here in a minute. I don't do that anymore, but you can do that, and I'll show you how these relaxing incisions, you're certainly justified in doing that, and usually you don't have problems with it. And then the flowering we'll talk about, that was something I learned from a colleague in the Dominican. Trypan Blue, just a little pearl on that. For conserving Trypan Blue, and I think for speed of case, I take the Trypan Blue in a 1 cc syringe, drop a half a cc of Trypan Blue, and then a half a cc of air. That air stays in place, and when you put your cannula in, the air bubble goes in first, fills the anterior chamber, you paint the capsule with your Trypan Blue, and I come right back with my viscoelastic, and the whole process takes about a minute, and you're done, and you're moving on with your case. You can get about 4 cases out of a 2 cc vial of Trypan Blue that way. So this is, if you're going to do a rhexis, a continuous rhexis, keep in mind these are large nuclei. And you don't want to have a lot of zonular dehiscence trying to pull a big nuclei through a rhexis you didn't make big enough. So be willing to extend it if you need to. Those 2 lines there are meant to be extensions, and I would tend to do more than that, but I put this slide up there on purpose because when I first learned this, that's how we did the whole case. We did not have Trypan Blue. We made a linear capsulotomy superiorly from 10 to 2, did the entire case that way, put the lens in, and at the very end did a D-shaped anterior capsulotomy to make an opening in the anterior capsule. Worked great. Rarely extended. So if we could have done if we did the case with a 1 slit, we can now do the case with a rhexis and 2 relaxing incisions. That being said, I typically would put in more than 2 because why not? If you're in there doing that, you might as well have more places for it to extend. I've kind of gone more to this. Carlos Gomez in the Dominican, we were working together on a project once, and I happened to be done early. I looked over his shoulders. He was doing a monster cataract, and he had this kind of flowery, make these little nicks in the capsule, make this kind of capsulorhexis relatively small. And I said, Carlos, how are you going to get this big nucleus out through that small capsulotomy? And he said, oh, no problem. It opens up like a flower. And if you look at that, if you think about when you put some pressure on that, there's a lot of surface area there. That circumference is going to expand quite a bit. So that's typically what I do now if I need to extend mine. I make these little tiny nicks, multiple places, and it does just seem to very nicely open up and allow that nucleus to come out. So this is a wordy slide, but it just is kind of talking through the next couple of steps. And I have a video coming up that'll show all this, but I'm not sure if it's going to play or not. So after you've done your rhexis, you want to hydrodissect the nucleus, get it, get it loose, and then you're going to rotate and express 1 pole of that nucleus. So you're going to push down on the anterior part of the nucleus, pop one side of that lens up, and then you're going to reach underneath that and start dialing it up and out, and just kind of dial it into the anterior chamber. This is one of those things you just need to do it and learn with a mentor, and it gets easier and easier with time. But you want that nucleus. I found it best if the entire nucleus is up into the anterior chamber. Some people get part of it up. I tend to have more capsule problems if I'm in it halfway in and out, so I tend to get the nucleus all the way up into the anterior chamber. There are other options. I tend to use my hydrodissection cannula because it's in my hand and it's fast. You can use a Cincy hook, a cystotome. There's a fish hook technique, which scares me when I see the videos, but those who do it swear by it and say it's a great technique. So here's my video that may not work. Oh, it is going to work. Good. Okay. So just going to do a little hydrodissection here. Pushing down on one side. I'm going to pop up 1 pole of that nucleus. Then getting up either at the equator or below. I'm typically below, kind of dialing up and out, and you can go in one direction, you can reverse. And then this is the irrigating vectus, which I like to use as well. posterior lip pressure. This is Dr. Hickman's video, so I usually use a little optic lobe rotation as well. But you can see the nucleus comes out very nicely. So steps to remember in getting the nucleus out of the eye. 1, irrigation, and not everybody does that. Some people don't use an irrigating vectus. I think it's helpful, and why not? It gives you a little bit of hydrostatic pressure to push the lens out. Opposite globe rotation, I take a Calibre or 0.12, I'm rotating the globe in the opposite direction, and then posterior lip pressure to kind of burp that wound open and slide the nucleus out. As far as the Simcoe cannula, just one couple quick notes on that. I tend to make my paracentesis a little bit bigger and about 4 clock hours to the right, so I can use my dominant hand to get the subincisional cortex. Practicing with your phaco cases, so it's just one less thing to learn if you're going on a mission project. Why have to learn a new instrument when you could have learned that, in a more relaxed fashion in your own OR? And then the catch and release technique is one pearl, and I don't know this is unique to me, but what I do is you tend with MSICS, you're going to end up with a slightly shallower anterior chamber. Your capsule is often kind of collapsed on itself, and you may have a small pupil. So you've got all this cortex out to the edge that you can't even see, with a kind of flattened anterior chamber, and you're sticking in an IA and you're kind of nervous about it. You want to grab the capsule and pull it to the center. So what I do is I go in with my Simcoe cannula and I kind of catch and release, and you're creating your aspiration with your thumb. Catch and, without moving the tip of the cannula much, catch, release, catch, release, catch, release. And you're gently tugging on that cortex, and pretty soon you'll see it come forward into the pupil, and then you can be more aggressive with it, grab it and take it out. But that, you're also using the cannula or the shaft of the Simcoe to kind of push down your capsule. And I prefer this. When I do MSICS in the United States, I use the Simcoe. I don't use the automated IA. It's a lot bigger diameter, burps your wound, and you have a lot more troubles keeping that chamber open there. So now let's switch gears a little bit and talk a little bit about challenges. And we could spend the next 2 hours talking about challenges and how to approach them, but we're going to pick one, which is small pupil, and then kind of highlight a few others just briefly. But this is kind of, when I teach residents, we want to kind of think through things and be as systematic as we can as surgeons. So we want to approach challenges with consistent principles, hopefully for consistent results, but even with that, we often, as we all know, run into unexpected things. And the challenges are not the same as complications, and that's a distinction I make with the residents, but challenges can turn into complications if we don't handle them appropriately. And there are lots of ways to go about these things, and these are just some of the things that have been helpful to me. So principle number 1, try to identify the challenge beforehand, try to make a plan going in terms of how you're going to deal with it. If you can make whatever is a challenge go away, that's my mind at least, it becomes a routine case. So then these things don't seem so intimidating. And then obviously we learn from what, either successes that we've had or less if we didn't handle it as well. So the bad news about this is that especially in mission settings, you're going to frequently deal with challenging cases. And in the US, when you're doing MSICS, you typically apply this to your most challenging cases. The good news is MSICS is a very robust technique, and as you become more adept at it, less and less of these cases will seem challenging to you. So small pupil, in my experience, especially with training people, this is probably the #1 risk factor for complications. You have poor visualization, you tend to be a little nervous about making the rexus too big, so it's a little small. Now you're having more trouble getting the nucleus out. Maybe you're getting too aggressive, you get zynoid dehiscence, and now you're dealing with vitreous loss, maybe even drop the nucleus. So anyway, it's something to pay attention to, be aware of, and deal with ahead of time. The more experience you get with it, it becomes less intimidating, but I think especially at first, it's just kind of a red flag. What am I going to do with this small pupil? So first of all, what is causing that small pupil? That's kind of the first thing. Prolonged dilation in some settings. Many years ago, we were out of the country, and we were doing just fine until noon. There was 4 excellent MSICS surgeons, and we took a break for lunch. We came back at 1 o'clock. First case, we were all operating in one room, 4 surgeons. First case, about 10 minutes into the case, vitrector please, vitrector please. 3 out of 4 surgeons asked for a vitrector on their first case after lunch. What happened? Everybody was dilated at 7 o'clock in the morning. The foreign nurses, we're going to be very efficient, dilate all these people. Well, by the time we were operating on them, they started to look good, but when we start working in the eye, the pupil comes down. So pay attention to that, and your pre-op protocol is part of that. Posterior synechia, easy to deal with. Pseudoexfoliation, I typically stretch the pupil, especially in mission settings. People are membranes, they peel them, and it's often a routine case other than maybe a small pupil. Pharmacologic, Flomax I don't see much in the developing world. Certainly we do here. I typically use a ring, a Malyugan ring with that. With MSICS cases, use the bigger ring, so you can get a bigger excess, and then take the ring out, because you can't get a big nucleus through that ring. I've tried, it doesn't work. So, and distinguish between, say, Flomax and pseudoexfoliation. You don't want to stretch a Flomax pupil. You do want to stretch a pseudoexfoliation pupil. And that would be my go-to for MSICS, because I don't have to take the ring out then, if I'm dealing with a pseudoexfoliation patient. Trauma, and then just sometimes we don't know why it's not dilating. So depending on the source of the problem, let's see if we can go, there we go, is our solution. So we can stretch the pupil, we can make sphincterotomies, synechiolysis, and the list goes on. So know what you're dealing with the best you can ahead of time, and then apply the proper solution to that. These are so stretching, I use this kind of cross swords technique. The cutting of the pupil, I learned this from Udo Dirksen in Paraguay. We were doing a trip together once, and coming from the United States, I want all my patients to look cosmetically, not only see well, but cosmetically look as perfect as possible. And we were operating right next to each other, and there was a fair number of small pupils, and he was not having any troubles, and he was cruising right along. He's moving a lot faster than I was, and I said, Udo, what's your trick? It turns out he goes superiorly, and he was doing a keyhole iridotomy on a lot of his patients because they had tiny little pupils. It's like, you can cut the iris? Yes, you can. And he said he does this all the time in his practice at home too, and it didn't bother the patient. That lid covers that. Sure, it's better to have a nice round pupil, but I would much rather have an irregular pupil and no complications and no lens in the vitreous, especially in a mission setting. So he gave me permission, in a sense, to deal with the iris, to cut the iris. What I do is I operate primarily temporally. First thing is I'm going to stretch the pupil. If it doesn't work stretching it, then I may make a series of very small sphincterotomies. If that's still not doing it, I just reach in temporally, turn my Van Ness superiorly, make one big cut. That's it. I don't have to do a keyhole because I'm not superior, but if you're superior, that's another way of doing it. So I guess I'm passing on that permission to deal with the iris. And I have not seen anyone complain when they've had a good outcome after MSICS just because their iris is a little irregular. And if you don't do that, sometimes even pulling your nucleus out, you're going to create a lot more iris problems. So just a bullet on a few other challenges. We've talked about pupil. If you're unable to get the nucleus out of the bag, you probably didn't make your rexus big enough, or maybe you need to work on your technique, but you can do your relaxing incisions. If you can't get the nucleus out of the eye, enlarge your corneal incision. There is one problem that you will kind of go away with over time, but it can still happen, is you can go and make a nice internal opening, but your keratome went in two planes. You don't realize it, but there's a nice little isthmus in between. So you only have a half of an opening on either side. So make sure that's open all the way across internally. That, especially starting out, that's a somewhat common problem. If you happen to go through full thickness sclera when you're making your scleral dissection, don't ignore it. Even if it's a small, you see a little bit of blue uvea there, I think it'll be fine. When you cork that nucleus into the internal wound and the pressure goes up, that uveal tissue is going to herniate through that wound, and it'll definitely slow you down. It'll get your attention. So better to just suture that. Be very careful, because obviously the uvea is very vascular, but I've seen that a few times, and usually you suture it, it's not a problem. Iris prolapse, that means you went in early. So when I'm teaching people or they're telling me about a case, I said, this iris prolapse, what do you think caused it? You went in early. How do you know you weren't there? Well, you went in early. That's what causes iris prolapse. So just be careful not to damage the iris the best you can, especially taking the nucleus out. I think it can get trapped in there and kind of create a dialysis. Non-sealing wound, most of the time it's because you went in early, you don't have enough of a corneal lip. Occasionally, in one of my cases, I thought I had a beautiful wound. The next day I had a little bleb leak, or a little bleb over where the contrast, and I said, what in the world, where's this coming from? And sure enough, under the slit lamp, I could see a little tiny piece of nucleus or epinucleus that was just lodged in the internal part of my wound, way off to the side, and I just missed it. And it was just kind of gaping, that part of the wound. So, Just one slide here on educational resources. A lot of them out there, a lot of YouTube videos out there, and I'm sure there's other resources. These are two that I've found that help a lot. Glenn's DVD series is excellent, and the Iravan manual continues to be a great resource. You can get both of these. They're available on the globalsight.org website, and the Iravan manual, I think, is available as a free download. So closing tips, just say yes, and the rest is logistics. That is really true. I think the biggest hurdle for any of us to, one, learn this procedure or to get involved with mission projects is to say yes. And once we say yes, you'll just start marching down that path of figuring out the logistics, where you're going to go, who you're going to work with. And I don't think you'll regret it. I don't think I've ever heard anybody do a mission project or learn M6 and say, oh, I wish I wouldn't have done that. That was a waste of time. So. And then if you're learning this, my suggestion is work with a mentor. And some of the criteria that I think work the best, you want a dedicated instructor who is going to teach you. Bad to go on a project, 2 surgeons, one experienced, one learning. And now we're going to go to a place of great need, and you're going to try to do 100 cases, 150 cases in a week. Great. Well, you're only there to slow them down, and that's going to create frustration for you and the other surgeon. So best is, let's say you're doing 100 cases in a week, and you can do that reliably with 2 experienced surgeons. Bring 3 experienced surgeons. One of them is dedicated to teaching you with a 3rd scope, and you get to go as slow or as fast as you want, and you're not having any pressure, and they're not feeling burdened that you're there and you're slowing down the process, and the patients are being taken care of. Plus, if you do that, you've got 3 teachers, not 1. So just a thought. And then pass on your knowledge to others as you learn, and just enjoy the opportunity we've all been given to restore sight to the blind. So thank you.